Karim Touijer. Para nuestro servicio es una enorme satisfacción poder contar en esta edición con el doctor Touijer. Iba a venir el pasado año y unas circunstancias de última hora lo impidieron y dijo que iba a venir este año y aquí está. O sea que muchísimas gracias, Karim. Te presenta el doctor Goya.
This is yours,
Okay.
and this is yours.
Yes.
Okay. Espera. El pasador que está. Did you? No.
No, I don't know.
Yeah, sorry. Just that and that.
Okay. So this one.
¿Cómo se pone aquí el de tope?
Next.
¿Cómo se pone el
This
grande?
is forward, next, and this is last.
Okay. Here. I'm going to sit while you can talk.
Ok. Bueno, buenos días, soy Gregorio Garmendia, adjunto del Hospital Donostia. Es para mí un honor presentaros a Karim Touijer, a quien todos vosotros conocéis. Os cuento en una pequeña introducción cuál es nuestra relación con él. Comienza con una estancia que tuve el honor de tener en el Memorial, que es este hospital de aquí, sacado con una mala cámara que es mi teléfono, un hospital que os aseguro abruma cuando vais allí y que, bueno, para mí fue una experiencia irrepetible. Un hospital referencia mundial en el tratamiento de la oncología, no solamente la oncología urológica, y bueno, con un montón de urólogos, pero desde luego para nosotros nuestra referencia y con quien queríamos estar era con el doctor Touijer. Le conocéis, sabéis de sus publicaciones, sabéis de su capacidad, sabéis de su constante innovación, sabéis de su destreza quirúrgica, que ayer mismo nos demostró una vez más en nuestro humilde masterclass que organizamos en el predúo del Hospital Donostia, con una nefroterectomía laparoscópica y una prostatectomía radical, que pasará a los anales de nuestro centro, desde luego. Para nosotros fue auténticamente espectacular. No le voy a echar muchas alabanzas porque es un hombre discreto, pero voy a hacer solamente 3 comentarios. Lo primero, es un urólogo que dentro de la Uro-Oncología no utiliza la robótica. Podéis suponeros lo que supone esto de presión y de competencia en un centro como aquel en el que pegas una patada y salen 8 robots. Entonces, bueno, él asume esta competencia y no solamente él asume, sino que puede con ello. Y bueno, es pues bueno, que todo el mundo quiere estar con él, por decirlo de alguna manera. La segunda cosa muy importante que a mí me gustó mucho al conocerle es que huye del puro empirismo, ¿no? Que muchas veces cometemos el error de caer, al menos yo. Es muy científico, todo tiene que estar pesado, medido, comparado y cualquier cambio debe estar sometido, digamos, al escrutinio de los ensayos, de los... Aquí veis, esta es una de sus publicaciones. Le gusta mucho que todo esté demostrado y no procede a ningún pequeño cambio, sino está claramente... La tercera cosa es que es un grandísimo anfitrión, para mí lo más importante y mejor persona. Nos atendió como si fuéramos amigos de toda la vida. Aquí está Teresa, también compañera del Hospital Servet. Y bueno, la verdad es que para nosotros fue una cosa que, ya digo, cuando vas a un hospital tan grande y que te abruma y una personalidad como la suya, bueno, pues fue para nosotros, nos lo puso muy fácil. Ha aceptado venir donde nosotros, le hemos machacado a trabajar después de un viaje larguísimo, nos ha dejado nuevamente impresionado. Karim, muchísimas gracias, ven cuando quieras y todo tuyo.
Thank you very much, Goyo. And it's an honor and a privilege to be here, and I would like to thank Juan Pablo for inviting me and the scientific committee. It would be a pleasure to be here. And so this presentation, I think you probably heard most of it from the wonderful presentation right before me. And but I will give it another angle. So this is probably how we surgeons see all the clinical trials and what's happening in our disease. And so, let me just figure this out. So, this is the clinical state model of prostate cancer as designed by Howard Scher. And as you could see, our patients, at least our surgical patients, start here, and the natural history of the disease progresses. This clinical state model provides a framework for us to do clinical trials and to ask questions, how we can help patients with prostate cancer. And there is a bar right through here which pretty much separates the cancer that we can attempt to cure versus the cancer that we try to halt the disease and try to prolong survival as much as possible. And this framework also had the historical line of when patients hit chemotherapy. So there is a pre-chemotherapy phase and there is a post-chemotherapy phase. So if you were treating patients, and I see a lot of young doctors here, if you were treating patients in 2004 and before, these were your options. If your patients moved into a castrate resistance, you were lucky because in 2004, docetaxel was the innovation in the management of prostate cancer as a single-dose chemotherapy. With better understanding of the functioning of the androgen receptor, we have hit an unprecedented era in the management of prostate cancer. And today, these are what our younger colleagues are dealing with. And so there is a plethora of drugs that have shown to prolong survival in prostate cancer, that have shown to give us an option in treating these patients. And I will not go into the sequence and the choice of these therapies, but I'll show you how we got to that. And so in the clinical state model, we started testing these drugs in the post-chemo when almost all failed. You've seen these trials, cabazitaxel after dosi, positive trial, ABI, positive trial, ENZA, positive trial, and radium-223. So for a disease where we would hit, in baseball they call it a home run, is basically almost like Cristiano Ronaldo's goal against Juventus, something that doesn't always happen, but is so spectacular. So for this to happen in our management of a cancer, it's phenomenal. And so then we moved from the post-chemo to the pre-chemo. We're trying these strategies earlier and earlier on. Again, more positive results. Abiraterone showing positive results. You could probably say, well, these curves, the separation is not that much, but nearly half of the patients had crossed over from prednisone alone and received abiraterone. And this is an intent to treat analysis. Again, the PREVAIL trial with enzalutamide, positive trial showing better overall survival, better disease progression-free survival. Then recently, the chart had just surprised everybody. Came up with positive results with chemotherapy at an earlier stage. So that line of pre-chemo, post-chemo now gets blurred, but the positive results of the chart, as you heard earlier from the excellent presentation prior, is that the positive results are mainly in the patients that have a high burden of metastatic disease. Then you see where this talk is going. We started at the back in the post-chemo, and now we're moving towards more clinically localized disease and more earlier phases of the disease. And so again, it's positive trial over positive trial. The Latitude trial was done in metastatic castration-sensitive prostate cancer, showed that abiraterone at this stage also can provide a better results and a better overall survival. The Stampede trial, which is a multi-arm, I mean, it's an incredible operation to run in this disease, is also positive, both for failure-free survival and overall survival. So, and the Stampede is in hormone-naive patients. Now, if we look at the Stampede, and so for us surgeons, this is where, if you look carefully at the data, you realize that the Stampede had 52% of the patients enrolled had mainly bone metastatic disease, but about 48% had either locally advanced high or high-risk disease as defined by either node positive or clinical stage T3, T4, or a combination of Gleason 8, 9, 10. So certainly this is a patient population where before we didn't think about systemic therapy. And in fact, this is a patient population where before we did not know what to do. And so then comes the PROSPER, also in non-metastatic castrate-resistant prostate cancer. The endpoint is metastatic-free survival, also showing activity. So the idea that the systemic therapy is for the later stages is migrating through that framework I showed you in the first slide towards more and more earlier disease, high-risk, locally advanced disease. And so we'll go back to that framework, and what you will see is now systemic therapy is moving that way. And if you look at the clinically localized disease, that's also a disease state that is changing. We broke that down into low risk and favorable intermediate risk, for which today, at least in my practice, mostly the low risk are active surveillance patients. We don't treat those patients, which means that as surgeons, we have to operate. So we got to look for a state that we can try our wonderful operation, which is a paramount in the management of prostate cancer. Then we finally are going to address the question of locally advanced, high risk, and even the newly diagnosed metastatic prostate cancer. The idea, and this is the concept that we will speak about in this presentation, is that today, this state, patients that are diagnosed with metastatic upfront disease, the natural history is they're going to develop the castrate resistance and eventually will die from prostate cancer. The idea is to bring together a multimodality that will bring potent systemic therapy, radiation therapy to the metastatic site, and eventually surgery to the primary, and hope that maybe this is the answer. So many of you would know who Whitmore was. We consider him in the US as the father of urologic oncology, and he was a chairman at Memorial for a very long time. And back in his time, Whitmore has challenged us with the following questions in prostate cancer. For all of you working in prostate cancer, you have to define whether his cure is necessary when it's possible. And his second question, which will be the part of my presentation, is cure possible when it's necessary? The newly diagnosed metastatic cancer, the high risk, the locally advanced prostate cancer. And I think today we are prepared, we have all the tools to finally address this challenge of Whitmore, that maybe cure would be possible, but we have to study it in rigorous clinical trials. So the newly diagnosed synchronous metastatic disease, prostate cancer, the incidence of this state varies from one country to another depending on how much are we utilizing PSA screening. So probably I think the incidence today will be somewhere from 3 to 20%, depends on the countries. But the disease remains highly lethal. Only a third of the patients will survive at 5 years. And what strategy do we have to treat this lethal disease? Hormonal therapy is the current standard. Hormonal therapy, we know that these results are predictably poor. These patients are going to respond to the disease initially, to the treatments. Resistant clone will take over, and patient will progress through castrate resistance, metastatic disease, and eventually die from either the disease or something else. And so the therapeutic objective that I'm going to speak about in this trial is, can we halt or cure this disease that we know is incurable with single modality therapy by using a multimodality therapy? This concept is definitely not new, and our colleagues in medical oncology know that. It's widely used in colon cancer. It's widely used in ovarian cancer with success in some cases. So certainly prostate cancer, it's prime time now to also derive all the benefit of a multimodality approach in trying to stop the disease process from progressing. Retrospective data, which sometimes gives us signs to follow and generate hypotheses, shows this is a CULP paper based on a SEER, which is a national registry in the US, showed that men that received radical prostatectomy or brachytherapy when they had oligometastatic disease end up having a better overall and 5-year cancer-specific survival. The next retrospective data, personal experience from Germany, also showed that there is a longer time to clinical progression, better cancer-specific survival. But what this data tells us is basically this is selection bias. So men that we knew would do well, we did radical prostatectomy, and then they did well, and we thought that's because the radical prostatectomy is what caused that. It's not. It's just we selected patients, and we created an answer before the question. And so this is certainly a place where we should do clinical trials. What we know today is that androgen deprivation therapy is not the answer. We know that we have 5 or 6 new agents with different mechanism of action that have prolonged survival. And fortunately, we all know that these potent drugs have not stopped the disease process, have achieved a slowing of the progression, better prolonged survival, but have not cured anybody that I know of. What this trial that we will talk about and design together is, what if we test the role of treating the primary in concert with treating all the other disease sites? First, we have to ask, this potent systemic therapy, what does it do in the prostate, in the primary, by itself? This is the data about the various recent neoadjuvant trials. I think this has been championed by Mary Ellen Taplin in Boston. And what it shows that these prostate cancer that were exposed to either ANZA, ABI, and various strategies of hormonal therapy as well, showed that in the prostate, if we give this neoadjuvant therapy and we operate on these patients, in about 5 to 10% of the time, the prostate pathological stage is PT0, that there is a complete eradication of the cancer. This is very encouraging. To my knowledge, you could ask the question, well, you have achieved PT0, but does it mean there is a therapeutic benefit? I can only find one abstract that showed that it does correlate with a better outcome. But it's not important. At least we know that the mechanism of action of these drugs could, in about 5 to 10% of the patients, be potent within the primary. We also know if we design this trial and we say we are going to give patients with oligometastatic prostate cancer systemic therapy, we're going to treat the metastatic sites with radiation, we're going to treat the primary with surgery or radiation, and we are going to continue systemic therapy, then stop, and then see what happens to the PSA and what happens to these patients. Data that has compared, and there are a lot of randomized trials that compared continuous versus intermittent systemic therapy have shown that it's safe to do that. So there's no worry about that. Then how do we get the primary endpoint? The problem with this data is, with this trial is, we have the systemic therapy, but we don't know which combination and which sequence we're going to use it. We know the surgery, that's a constant. We know radiation therapy, that's a constant. And so if we build a trial looking at disease-specific survival or looking at overall survival, we will have the results 5 or 10 years from now after $100 million. So that trial is good, but it's probably not the answer. Where we are and what Howard Chair and our institution proposed is to build the same framework as the Stampede, but small amount of patients, and use the PSA as a quick readout whether we have inactivity or not. And so it's binary and detectable versus detectable after surgery, and you know whether this strategy is working or it's not. And all you need is a small number of patients, so it will be a quick, easy way to generate data to build a larger trial. And so radical prostatectomy for the oligometastatic is its only for few carefully selected patients and is a thought that needs to be put to test. It's not something that tomorrow we should start offering radical prostatectomy for metastatic patients. So before we built our trial at Memorial, we did a pilot study to see whether it's safe to do surgery in patients that have metastatic disease. We had 20 patients. Their metastatic burden was diagnosed either by whole body MRI or PET scan. What I mean by PET scan is FDG PET. At the time, we did not have the PSMA. Patients received systemic therapy for 4 months. They received surgery, and the type of the surgery that they received was either radical prostatectomy and pelvic lymph node dissection, or radical prostatectomy, pelvic lymph node dissection, and retroperitoneal lymph node dissection if they had retroperitoneal nodal disease. And then we treated the bone metastasis when they had bone metastasis with radiation therapy. And so this is the patient characteristics. Most of these patients had Gleason 8-9, as you would expect. Some of them had the majority had bone disease, and some of them, 4 patients in this trial, had only retroperitoneal lymph nodes and did not have bone metastasis. And so the majority of the patients received 4 months of androgen deprivation therapy up front. And when we did retroperitoneal lymph node dissection, we actually asked our colleagues that treat testicular cancer to do that part. And they did it just exactly if they were doing it for testicular cancer. They cleaned the whole retroperitoneum. Then we did the pelvic and the radical prostatectomy in the same setting. And so the results, the pathology is as expected. We didn't see any, it was safe. The continence was about the same. About 90% of the patients were continent. There was 1 grade 3 complication, which was an infected lymphocele. Otherwise, this was very well tolerated, just as if we did radical prostatectomy outside of the metastatic setting. Now, what happened to these patients? So we were able to stop androgen deprivation therapy in 6 patients. The others, either they developed new metastases, or probably they had metastases that just showed up, or their disease progressed. And so these are the 6 patients. Remember, this is a pilot study, and it's just to establish safety and generate data. But by looking at anecdotal cases, it's just telling you, it's not to say, does this work? No, it's just to say there is maybe a signal. And so I want to get your attention on these patients with the blue arrow, and I will give you his data right now. So this was a 53-year-old man. He had a PSA of 7, and he had a Gleason 9 clinical T3B. He had a metastasis on the bone right there. That's quite evident. And this man basically received combined androgen blockade. So the red line is his PSA. His PSA dropped to undetectable. And he had radical prostatectomy, and post-radical prostatectomy, his PSA started to rise. Then we started him on abiraterone. And then treated that bone lesion with focal radiation therapy. The blue line is his testosterone, so he has completely recovered his testosterone. The last data I showed you is 600. His PSA remains undetectable today with no castration. And so far, as far as we know, he's cancer-free with an undetectable PSA. This was unheard for us. We haven't seen this before, but this was quite a remarkable response. Probably don't know why he responded, but the bottom line is this combination worked for him for his disease. The second patient, not as spectacular, but his PSA in red dropped with combined androgen blockade. He had radiation therapy to the bone metastasis, followed by radical prostatectomy. The blue is his testosterone recovery, and you could see the line is he had a good 2 years with undetectable PSA, and then after about 2.5 years, his PSA started to slowly rise. How did we help this patient specifically? He had 3.5 years without systemic therapy. So maybe we didn't achieve cure, but we were able to delay systemic therapy. I think that's also a good signal to study whether this aggressive multimodality approach is helpful. So the trial that we put together is called the MetaCure, And the hypothesis of this trial is exactly as I said, is bring all the treatments we have from an aggressive standpoint and try to see if we can help some of these patients. We know, this is Wasim Abida from our center. He did genomic sequencing of over 1,000 prostate cancer. And what he has shown here is the local regional disease and the metastatic non-castrate, which is the green and the gray lines on your right-hand side, have almost the same genomic landscape. So perhaps what would apply to the local regional, what would, in terms of therapy, and to the non-castrate metastatic would be almost within the same trunk. And so we started the Medicure trial about, it opened about 4 months ago. The way it's designed, and you can see we only enroll in a total of 30 patients, and we're looking at PSA response. This is to have a strategy, figure out quickly if it works. If it does, then we will go to a phase 3 trial. If it doesn't, then we'll flush it and go back again to the drawing board and trying to figure out what the strategy. So this trial has an arm. The PI is Howard Scher, that many of you know. So what this trial has an arm where patients will be randomized to either receive hormonal therapy, androgen deprivation therapy with apalutamide, or apalutamide, abiraterone, prednisone, and hormonal therapy. They will have stereotactic radiation therapy to the bone lesions. They will have surgery, and then based on their results, we'll decide whether they might need adjuvant radiation therapy to the pelvis. And then we will follow their PSA response. The other arm, because now it's almost okay to combine the locally advanced with the oligometastatic in the same sort of treatment strategy, not in terms of prognostic category, but just how we approach this disease. This other arm is androgen deprivation therapy plus apalutamide, or a combination exactly of apalutamide, abi, and prednisone plus ADT, surgery, adjuvant radiation therapy. These patients don't have metastatic disease, so we will see whether this aggressive strategy works. And then finally, the last arm has to do with patients that had radical prostatectomy, had biochemical recurrence, and then we were treating them with radiation and systemic potent systemic therapy. Now, I think it was mentioned earlier by Dr. Rubio, today we have results from 2 trials that have looked at this question of treating the primary. These 2 trials did not use radical prostatectomy, they used radiation therapy to the primary. This is the Horrid Trial, which came out about, I think, 4 months ago or so. So the Horrid Trial had a bit smaller trial, over 200 patients per arm, either androgen deprivation therapy or androgen deprivation therapy plus radiation to the primary. This trial was negative. This trial also had about 67% of the patients had high burden metastatic disease. The other trial that you spoke about is the Stampede Trial. And the Stampede Trial, if you look at arm H, it had radiation therapy to the primary. Stampede Trial just published Sunday, this past Sunday. And the results of the patient characteristics, as you could see in this Stampede Trial, which uses radiation therapy to the primary, showed that about 42% of the patients had low metastatic burden, 58% had high metastatic burden, and the overall results for the whole cohort did not show any benefit in overall survival. However, if we look at the data by low metastatic burden, high metastatic burden, there were significantly positive results of administering radiation therapy to the primary in the face of metastatic disease, and you could see it on your left hand. Now, often when you see trial and you see subset analysis, you wonder whether the trial generated enough power, was designed to be sound methodologically to support this. And the authors of the Stampede trials did take that into consideration, and the trial was powered for subset analysis here for the low metastatic burden. So Stampede, I think, should be considered as a positive trial in the low metastatic burden in terms of treating the primary. So there is, again, more and more confirmation that in the locally advanced, in the oligometastatic, single modality is not the answer, and multimodality is. The Peace 1 trial, that's part of the GTUG RTC, is ongoing, and so is this trial at MD Anderson that we call the Other Cancer Center. Now, let's talk about immunotherapy. This is a slide from Jim Allison, and this is the slide that got him all his work, the recent 2018 Nobel Prize in Medicine, which basically has to do with the immunotherapy and the CTLA. And so from that work developed the drug development of ipilimumab, which is quite positive in melanoma. It's the startling results of the application of ipilimumab. We took IPI and we used it in a trial of not so oligometastatic disease at our center. This is not published data. And so this is a small trial, and the idea was that we will expose patients with metastatic disease to androgen deprivation therapy, which releases antigens, stimulates the antigen-presenting cells, trigger the immune response that we will treat with the ipilimumab. Then we will do radical prostatectomy and generate, again, more immunologic stimulation that will turn into a positive result. So that's sort of the theoretical background of this question. This is the schema. Patients will start on digarelix injection and IPI. 2 to 3 weeks later, they will receive surgery, and then they will be followed with digarelix for a recovery period, and then they will get 3 doses of IPI at 10 milligrams per kilo. And then after the 8th dose of digarelix, we stop, and the endpoint was PSA at 12 months or PSA at 20 months, depending. And so these are the patients. We enrolled 16 patients on this trial, and we had 2 doses, either 10 milligrams per kilo as was used for the melanoma, or 3 milligrams per kilo. With the 10 milligram, we had quite a bit of toxicity from that. And so I don't have the overall results on this trial, but I will show you this one patient that you see here that received 10 milligram. He was a patient of mine. This was a 69-year-old man, PSA of 30, clinical T3A N1 disease on imaging. This man had bone metastases, oligometastatic disease in the ribs and the humerus. He underwent IPI, digarelix, radical prostatectomy in 2015. In the prostate, there was adenocarcinoma with hormonal changes, with effect of the hormonal therapy. He had 33 lymph nodes that were negative and negative margins. This is his PSA kinetics for the last 4 years. So in 2015, he received the hormonal therapy. His PSA was about less than 2 when we did the radical prostatectomy. His PSA is undetectable up until October of this year when I saw him. So maybe there are some patients might benefit. We don't know. Maybe we should pursue immunotherapy. Unfortunately, ipilimumab in 2 randomized clinical trials, phase 3, had disappointing results. At the recent 2018 ASCO, Johan de Bono presented this Keynote 199 study, which had patients in 3 cohorts. 1 cohort had PD-L1 expression, 1 cohort did not have PD-L1 expression, and 1 cohort was regardless of the PD-L1 but had bone mets with no measurable disease by RECIST criteria. And so these patients were treated with pembrolizumab. This is the patient characteristics. The results basically showed that in a small fraction of patients, pembro had a clinical activity, and there was a stabilization of the disease. Although what is surprising in this trial is that the same response was obtained whether patients had PD-L1 expression or not. If we look at the work by Wasim Abida at Memorial, screening and doing genomic sequencing and looking at microsatellite instability high or the DNA damage repair gene panel across a number of cancers, What he had shown for what interests us is that about 2 to 3% of patients with prostate cancer will have MSI high genomic expression, and about 50% of these patients will eventually have some response to immunotherapy in this setting. In terms of immunotherapy, I will just give you a bit of a list of the trials that are currently underway. This one is atezolizumab and radium-223, ongoing with a complex schema. There are 3 other trials that are also registered and enrolling patients looking at combination of Immuno-Oncology with PARP inhibitors. Now, where is immunotherapy in prostate cancer today? I think it's under study. We need biomarkers to help us select the patients that might benefit from this, but it's an area of work that hopefully will be as spectacular as what we've seen in bladder cancer and eventually in kidney cancer. Now, I just want to share with you that at Memorial for about, I think, 5 years now, of the patients we treat, we do genome sequencing for about 483 genes that are commonly mutated in cancer. What this data hopefully will help us get some insight on is generating a lot of drug discovery and changing our mindset from treating patients with protocol based on the organ where the cancer started, but more based on the genomic mutation that cancer has. So patients with bladder cancer or breast cancer will have an overlap of treatments the same way as patients in prostate cancer. Right now, it's in a phase of accumulation of data and readout on the data, so I don't have any information to tell you that there has been any major breakthrough, but certainly the story of the DNA damage repair genes, the BRCA1 and 2, the ATM gene mutation is certainly actionable in prostate cancer. And the complexity of treating metastatic disease is certainly laid into this paper. I don't know how many of you are familiar with this paper. So this is basically a patient that was treated at Johns Hopkins, and throughout his progression of disease, there was tissue from the primary, tissue from the lymph node, tissue from each metastatic site, and then they did sequencing of all these metastases. And it's quite surprising what happens. First, there is heterogeneity. This is the prostate that you see there. And basically, if you see at the top left corner, this patient's all metastases came out from that clone of cells that is called P1 here for mapping. And if you look at the mutation panel, all the metastases on the right side here have exactly the same genetic mutation signature that small focus of cancer is what would kill these patients. He did have a lymph node metastasis, but it had a completely indolent genomic and did not play any role in the demise of these patients. So to make the story simple is we should just know which one is the lethal clone and we'll figure out how to treat it, but it's not as simple as that. The problem is when we give treatments, we may be, for example, hypothetically, we could treat all the tumor burden except that clone of cells that is resistant. And so what we do is we keep selecting resistance, and that's what takes over later, and that's what happened in this patient. So certainly there is a lot of heterogeneity in the cancer we treat. We're lucky today because we have our armamentarium in terms of managing the disease is quite ample. We have options, and I think we should continue in trying to ask the right question with the right methodology to try to treat some patients and divert that natural history of the disease that is going to death from cancer or death from other causes. Thank you very much.
Muchas gracias, Karim. ¿Alguna pregunta desde la sala? Bueno, yo reconozco que me he perdido un poco en algunas diapositivas. Parece claro que el tratamiento debe ser multimodal y parece que esto incrementa desde luego las indicaciones, ¿no? Recordando un poquito lo que es el cáncer renal. ¿Algún comentario?
también se ha comentado antes, o parece que esto es un planteamiento de estudio, pero es lo que se ha comentado antes, ¿no? Que decía la doctora Nina Tunariu, de cuanto más en pacientes de baja carga tumoral, metastáticos, igual tengas bien identificado al paciente y su situación, más oportunidades de hacer tratamientos multimodales vas a poder hacer, ¿no? Cirugía, tratamiento hormonal, tratamiento con radioterapia de la lesión, para conseguir, no sé si la curación, ¿no? Pero sí largos periodos de evitar tratamientos, un bloqueo hormonal continuado o la incorporación de nuevas moléculas y su toxicidad. O sea, que es retrasar la evolución de la enfermedad, ¿no? Es un poco lo mismo. Lo que pasa es que es un planteamiento sumamente atrevido, ¿no? Pero que en casos concretos bien seleccionados, yo pienso que va a pasar, ¿eh? No sé con qué, pero sí que lo pienso, que se va a dar, vamos.
I agree. I think it's time for a multimodality approach. That for a disease that, although takes a long time to be lethal, the single modality answer, the shift from one modality to another has not been working. And we have enough data that perhaps using, in whatever sequence, using this multimodality approach is the way to go. This is not time for antagonizing specialties or treatment option. It's not about which option is better than the other, is which combination of these options will be better in these patients.
Hay una pregunta allí, por favor.
Hi, Karim.
Hey, Mario.
How much useful was to do the retroperitoneal lymph node dissection for your patients when you have done this in patients that have more than 2 centimeters and node positive in CT scan? How much patient do you discover positive nodes? Because it's a limitation from this surgery, no?
Yeah. So that's probably one of the riskiest thing to do in that phase, that pilot phase, is because we expanded the surgery to a large retroperitoneal lymph node dissection. There were 4 patients that underwent retroperitoneal lymph node dissection. They all had positive nodes in the lymph node, in the retroperitoneum. They tolerated the procedure well, but it was not a radical prostatectomy. It was a much bigger operation. Today in the Medicure trial, we are allowed to do that. And I know you do a lot of robotic surgery. It is possible to do it robotically and without too much trouble, because with the new robots, you can, in a patient in a lithotomy position, you can turn it around and do the retroperitoneal lymph node dissection. Now, the question is whether that's helpful or not. I think we will know from the trial. But often when you work with our colleagues from medical oncology, it's a different question. It's basically removing all visible disease and achieving sort of the response rate. And then we will follow and see if that's helpful. If nobody fails in the retroperitoneum after that, I think it's a winning strategy. But that's a hope more than anything else.
Bueno, pues nada, damos por concluida entonces la sesión de la mañana. Karim, muchísimas gracias y nada, nos vemos enseguida.